Today's episode is fascinating. I'm going to be diving deep into the world of gender surgery. And to that end, I'm going to be joined by one of the world's experts and one of the very first gender surgeons in the UK, James Bellringer.
In terms of the specific risk of surgery, what worries me most, every time I start doing an operation I worry about it, is making a hole in the rectum.
What is gender surgery? Well, it's a type of surgery that permanently alters a person's body part associated with their biological sex. In simple terms, gender surgery involves things like creating a new vagina, a vaginoplasty, removing a person's testicles, an orchidectomy, removing penises, a penectomy, and way more. And if you've got a question for me to answer, head over to thereferralpod.com and get in touch. Excitingly, today you're going to have another brand new shiny episode of Crowd Science Extra. This episode will be dedicated to all things health, science, and medicine, so feel free to get in touch at thereferralpod.com and ask your questions. And a bit later, we have If It Ducks Like a Quack, that bit where I debunk all of those silly myths that you hear online or in the real world. But first, it's What the Health. What the health is going on in the world of medicine, science, and health.
What the hell?
So it turns out your number twos could be the number one defense against liver disease. Now, I'm not suggesting you start munching on your feces to improve your liver, although some pseudoscientists may eventually start to proclaim that, and you definitely should run away from them. But there is a new trial that's going to be started by King's College London to investigate fecal microbiota transplants, poo pills or capsules, to help patients with liver disease, specifically liver cirrhosis. Now, if you're interested in learning a lot more about poo transplants and your microbiome, go and catch the episode I did with Dr. Blair Merrick, and we go into the nitty-gritty of poo pills, and that is fascinating. But in this study, what they're proposing is that they could take good bacteria in the form of fecal microbiota transplants and give them to patients with advanced liver disease and liver cirrhosis, because it's thought that patients with liver cirrhosis have dysbiosis, a increased amount of bad bacteria and a scarcity of good bacteria. So if we can transplant good bacteria in these poo pills into these liver patients, we can improve their gut microbiome and reduce their risk of infection. Because if a patient with liver disease or advanced liver cirrhosis gets an infection, it could potentially be fatal. And a lot of patients with liver cirrhosis, they often end up on different courses and recurrent courses of antibiotics, and they develop antimicrobial resistance. One of the unfortunate things with liver cirrhosis is that a patient, if they're infected with a bug that is resistant to any antimicrobials, then they would no longer be a candidate for a liver transplant, which is the only curative strategy we have right now for liver cirrhosis. So they've established the feasibility and safety of doing these poo transplants for liver cirrhosis patients in a very small study of just 32 patients in a European study, and they're hopefully going to replicate that in much bigger numbers in the King's College London study. And who knows? And you might think liver disease and liver cirrhosis, it's quite rare, but in the UK, it's the third most common cause of death. And that is your weekly dose of science news. But now for something even more interesting, my conversation with gender surgeon James Bellringer. Thank you so much for joining me. I know a lot about you because I was a medical student when you were doing your gender surgery in Charing Cross Hospital. But for those listening at home, who are you and what do you do?
I'm James Bellringer. I trained as a general urologist, but I moved into gender surgery, specifically feminising genitoplasty, which is starting with male anatomy, creating something that as closely as possible resembles female anatomy from a genital point of view.
So you offer gender surgery for those people with gender dysphoria who are female but are genotypically male.
Phenotypically. And phenotypically.
Yeah,
and
genotypically male, and who want to become phenotypically female.
They wish to resemble female as far as possible, yeah.
What do you define as gender dysphoria? What does it mean to you?
It's a deep, unmovable sensation that your external appearance does not conform with what's inside your head.
Okay. And how prevalent do you think that is in the world, not just the UK, in just general population, the incidence of something like that?
I mean, if you look at incidence across the world, it's pretty much the same everywhere. There's cases of underreporting where you've got repressive regimes. I mean, gender dysphoria is apparently quite uncommon in Russia.
Right.
It's quite uncommon in some other countries where you might expect it to be. Interestingly, it's above average in Iran, but there's other reasons
Why is
for
that?
that.
Is that because from a cultural point of view, they're more accepting of a third gender, or?
No, Iran's got its own problems. In Iran, if you're a gay man and you get caught with another man, you both get stoned to death.
Right.
I think that's the rules. But the Ayatollah said that changing gender was acceptable.
Okay.
And so a number of people actually say, well, actually, no, I'm not gay. I'm gender dysphoric. I'm really a woman. So there's a slight artificial increase there. So there are a few fluctuations, but globally, we think probably 1 in 60,000, 1 in 100,000 people.
Okay.
So it's rare.
It's rare, but on a the law of very large numbers, if you take millions and millions of people, that accounts to a significant number of people who are gender dysphoric.
Yeah, and surgeons around the world are all completely, absolutely snowed under.
Surgery for people who suffer with gender dysphoria, it's been going on, you could say, since the 1930s, or more in the 60s in the UK, but in the world, the 1930s in Germany.
Well, the German case, yes, and about, I think, 1932, 1934.
Dr. Hershing?
Yeah. I mean, that was feminizing surgery. There's no vagina.
No vagina. So that was removal of male genitalia. That was
creation of a vulva from male genitalia. That was probably the first recorded case.
Dr. Hershing in
Berlin.
In Berlin. But a lot of the anatomy and the medical records from that period of time were destroyed by the Nazis. Do you think, just hypothesizing and thinking about the techniques of surgery they used back then, how wildly different would they have been to some of the things you're doing now?
I think from the external point of view, quite a lot of similarities. I'm fairly certain they weren't creating a vagina, so that's a whole step onwards. And I think the first recorded vaginoplasty is probably in Britain. So probably around 1950-51, the operation would have been done.
So when you're doing gender surgery, what are the basics of what you offer and what you do?
I prefer to talk about the operations as they are. So the 3 principal operations which I offer are orchidectomy, so removal of the testes only, sometimes incorporating removal of scrotal skin, so that goes as well. Then vulvoplasty, where the male genitalia are essentially largely removed and a female vulva is made, and then vaginoplasty, which includes the vagina.
Now, creating the vagina and the vulva, I've read, obviously, you can use various organs, and including bowel as well.
Yeah.
How common is that?
As rare as possible. I in my career, I've done quite a few bowel vaginoplasties, and I'm quietly hoping I never do another one.
So how does that work? Do you have to do a laparotomy to remove a small section of intestine?
It can now be done laparoscopically. In fact, it almost invariably is done laparoscopically or robotically, of course, nowadays. But it's going down in popularity very rapidly because everybody's got very excited by peritoneal vaginas.
So taking the inner lining of someone's abdominal cavity.
The peritoneum is the layer of tissue which lines everything in the abdomen. And you can create a flap of that which you can swing down, which creates a full-size vagina. It's more complex than doing what I do, which is a skin tube. Well, I've done a couple, but it is far more complex. But we are seeing more patients now whose skin is inadequate to do skin tube vaginoplasty. And skin tube vaginoplasty, as we've been talking about, has been going for 70 years now.
And that is
it does well.
Skin of the scrotum or penis used?
Penis always, scrotum sometime as well. Penile skin's good because it's thin, hairless, stretchy, soft.
And it more closely resembles other parts of the body than the scrotal skin.
Well, the scrotal skin has its problems. It's wrinkly, hairy. It is quite stretchy. It's got its own muscle layer attached to the back of it. It's got fat attached to the back of it. Now, you can use it as a free graft. And you take all those layers off and you end up with just the skin. But it still grow hair unless you do something to the hair.
Now, the vaginoplasties and the neo-vaginas, the new vaginas that you create, how closely in resemblance do they appear to biological, genotypically female vagina?
I'd like to think that most people at a quick glance wouldn't be able to tell.
And is there some adaptation with the hormonal therapy, with the estrogen therapy, that makes it adapt into looking, more closely resembling a female vagina?
No, I mean, the estrogen doesn't do anything to it. Some people have actually used estrogen creams in these neo-vaginas. Does it turn into vagina? Well, it doesn't.
What about the clitoris? Can you also resemble that, and how would you do that?
Well, that's just a fortunate step in anatomy. A clitoris was described in about 1989, but it was not really sensate. It was a little nub of tissue. And then a couple of guys worked out how to do it with its own blood supply and nerve supply. So you end up with a small piece of tissue which is erectile and sensate.
Really?
And you can put that where you expect to find a female clitoris.
Okay, so
There's no such thing as a male clitoris. A female clitoris. Expect to find a clitoris.
So at the end of this feminizing surgery, can a transgender woman have a clitoral orgasm?
They report them, yeah.
They report them as well.
I mean, they do. They report them. I mean, if we did a study through our series at Parkside in 2017, and 75% reported achieving orgasm within 3 months of surgery.
So, you're offering this seemingly groundbreaking surgery. It's not a very common surgery. You are one of how many surgeons, gender surgeons in the UK? How many are there?
Well, if you're looking at vaginoplasty surgeons, there are 4 fully trained and 2 in training at the moment.
Wow. So there's going to be 6 in the next few years?
I'd like to think they're going to be rather more than that.
Right, because the
waiting
demand
times
is
are
increasing.
going up. I mean, for years we haven't been coping with demand.
So you trained as a urologist, as a specialist who deals with diseases of the urinary tract, the kidneys, the bladder, the genitalia.
Yeah.
What then led you on to going into gender surgery? Because it's a very, different path to take as a urologist. You were the first urologist I ever knew.
Well, gender surgery in Britain, genital gender surgery has always been done by urologists. I mean, the guys who do the phalloplasty, they're all urologists. They're not plastic surgeons. Worldwide, there's far more plastic surgeons doing it than urologists. But there's a few of us around. So the people who had been doing gender surgery were urologists based at Charing Cross. I was down the road at West Mid with one session at Charing Cross, and the guy who was at Charing Cross doing the vaginoplasties announced he was going to retire.
Yeah.
Cut a long story short, they said, oh, he could do it. Why don't we ask him? And because I already had a session at Charing Cross, they didn't have to go through having an appointment. They just had to say, we'll give you more sessions here and less sessions at West Mid, and you can come and do the gender surgery. And so they asked me, and after about 3 months thinking about it, I said yes.
So, this was over 20 years ago when gender surgery was far, far less common, and there was even more stigma about it in the world and certainly in the UK. What then pushed you to think this is going to be a huge thing, or did you already see the growing demand for it back then?
This was something I actually in the end wanted to do.
Okay.
To say I'm interested in sex that's obvious, we all are.
Yeah.
There's very few people who aren't, but actually professionally, I'd always had an interest in sexual medicine.
Someone's not going to just rock up at your door at your clinic or in the hospital and have feminizing surgery the same day. What is the process that someone has to go through until they have surgery? There's a long lead time of psychological evaluation and real life experience. What does all that involve?
Real life experience is gone, by the way.
It's gone now. Do you think it's good or bad that they've removed real life experience when someone is about to undergo surgery?
They've removed the term.
They've removed the term.
They've removed the term because it's a load of mumbo jumbo. Real life experience. What's that mean? It's daft. We talk more now about social transition.
Social transition.
So you have somebody who goes into their new social role in the gender they experience.
Right. Okay.
So if it was you, you'd have to have a shave to start with. So would I.
Do you? As in, does one need to shave?
I think making out that you're doing the full female role if you've got a full face of hair it's difficult to say you could be gender non-conforming, you could be non-binary.
So how
say
long...
you're female with a full beard that's
The social transition phase now, how long does that have to last before gender surgery?
A minimum of a year. That hasn't changed.
And what follow-up or contact do you have with these patients in that year?
I don't see them.
You don't see them at all?
I don't see them before they've completed that usually.
But you see them at the start and say they need to go into the social transition?
No. I mean, okay, I will occasionally have somebody who books themselves into my private clinic and says, hello, I want an operation, please. And I say, well, you know, where are you in terms of transitioning? Has anybody seen you who's a gender specialist? And they say, no, I just want the operation, please.
Who
and
keeps a track of the social transition phase to know they've adequately experienced that?
Well, in the UK, on the NHS, there are currently there were 7 gender clinics. There's 2 more opened up, or 3 more opened up already, and another one starting. So provision of gender counselling is increasing to try and meet the demand. I mean, there's a waiting time for surgery, but there's a 4-year wait to be seen on the NHS if you know...
To have your first appointment in a gender clinic?
If you went to your GP tomorrow, which seems, I have to say, unlikely, and said, hello, I think I'm really Karen, and I genuinely think I should have been a woman and all that sort of thing. Your GP could refer you to an NHS gender clinic, and the waiting time is a minimum of 4 years.
To be seen for the first appointment? So that's why a lot of people are going privately?
That's the main driver for going privately. I mean, patients who come to see me who want private operating, who come from the UK, I've got some coming from abroad as well. It's typically because they say, you know, I'm 28, 29. My first appointment in the gender clinic is going to be when I'm 32. Yeah. And I just don't want to put my life on hold that long.
So assuming someone has an appointment in the gender clinic, they are then asked to go into the social transition phase for a year, and then they complete the social transition, and then they see a surgeon like yourself.
And have hormone treatment.
And have, in the social transition phase, they are having hormones?
Yeah.
And then they complete all of that. What is the dropout rate you see in that year of social transition? Or people thinking, I don't want to do this now that I'm in this role?
Well, you're talking about a dropout rate. It's where people stop, where they get to being comfortable with their gender. For some people, they'll go along to the gender clinic and they'll have a period of intense counselling and get to the point where they're actually content to carry on as they are.
Without any surgical intervention?
Without surgical, without hormones, with nothing.
Okay.
And there'll be other people who cannot cope unless they go right along and have an operation. And it doesn't make them less gender dysphoric at the beginning. It just means that what's required to make them...
It stratifies the intensity of their management, that social transition phase.
Yeah, I mean, the important thing about the social transition and the hormone environment, of course, is if you're going to come to see me and have a vaginoplasty, I'm going to remove both your testicles.
Yeah, yeah.
So you're going to be...
Which is irreversible.
Pretty much, yeah. I mean, you know, so you're going to have no testosterone.
Yeah.
And unless you've experienced that before I've done it, it's... And if you find actually that having no testosterone is a bit of a bad thing, just imagine going through it without the social transition, without hormone treatment. So one day you turn up and you shave your beard off while you're in hospital, and the next day you go out no testosterone, wearing a dress and with a vagina. It's not going to work. I mean, for a lot of people, that's going to be a disaster.
If you remove someone's testicles, an orchidectomy, and you remove their factory of testosterone, we know testosterone is for more than just muscle mass, but for bone health, mental health, and various other things. How do you account for the steep drop-off of testosterone and the insidious effects of the sudden depletion of testosterone?
Well, they're all taking hormones anyway, so their testosterone level is reduced to zero or close to zero. Either by the use of GnRH analogues to start with, or if you give enough estrogen, it'll do it anyway. So they move to a female hormone environment, and because they've got estrogen on board, the mental health, diabetes, osteoporosis, and so on and so forth
is mitigated.
It's
by
not mitigated;
estrogen.
it's eliminated. If they're on appropriate estrogen levels, they will not get all those problems.
And you know, this is still a major surgery that someone has to undergo. What are some common risks that you see and catastrophic risks with this type of surgery that you've seen?
I've unfortunately had one death in my career so far. There was a patient who died from a pulmonary embolus, which, for the non-medical listener, is where a clot forms in the legs during the perioperative period, and a bit of that clot breaks off and it blocks the main artery to the lungs, and that pretty much stops the heart with the effect of instant death. It's fortunately a rare complication, perhaps 1 in 2,000 in major surgery, but we do our best to eliminate it, but you can't eliminate it completely.
Yeah.
In terms of the specific risk of surgery, what worries me most every time I start doing an operation, I worry about it, is making a hole in the rectum.
Yeah.
The rectum and the prostate are less than a millimetre apart in terms of
sharing the same wall.
There's a nice layer of fascia between the two, and you've got to get in the right side of that, and then you're safe. But every time you think you've cracked it, and you'll never. I know exactly how to do this now. I'll never make another hole in the rectum, and then all of a sudden one day you do.
Yeah.
And most of the time you repair it and it's fine and the patient recovers and doesn't have a problem and so on. But if you get a fistula, it's a major nightmare.
Oh, it's a lifelong, potentially a lifelong
well,
issue.
it's potentially it can potentially lead to a lifelong colostomy. Fortunately, most times it doesn't.
Now, I'm sure a lot of patients, once they undergo gender surgery, they feel great and you probably get plaudits from them yearly. But do you see a significant percentage or any patients coming in with any degree of regret and want any form of reversal? And is reversal surgery even possible?
Regret is fortunately pretty rare.
Yeah.
And regret comes in more than one guise. I mean, you've got people who genuinely regret, oh my God, I had my male genitalia removed.
Yeah.
I had female genitalia made. I've not got testicles anymore. And actually, oh my God, I want everything back. I wish I hadn't had it done.
But that's not possible.
That's not possible, and fortunately, vanishingly rare.
Yeah.
I've seen 2 patients, one of whom went to Thailand for surgery and was operated on without any real assessment beforehand. I think, as far as I recall, basically arrived in the surgeon's desk with a large case of banknotes and said, "I want a vagina, please." And he said, "Yes, okay, it's tomorrow soon enough."
Wow.
And came back and just sat in my clinic and cried.
Was the actual, from an operative point of view, was the surgery done well in Thailand?
They're very good technical surgeons, and they produce good results.
But the perioperative workup in the psychological evaluation and all those things are not done to a higher degree.
They're working on it.
Yeah.
I think the Thai the Thai regulatory authorities realised that they potentially had a problem with the sort of questions asked that some, not all, of the Thai surgeons were adopting, say, 15, 20 years ago. So it's got a lot tighter now. They are actually asking to see some psychological workup.
Something interesting I read a while back about a gender surgeon in India, Dr. Kaushik, in a transgender clinic in Delhi. He said he wanted to be the first surgeon to implant a uterus into a man as part of feminizing surgery. Do you think that is, at any point, given our current science or in our future science within the next decade or two, feasible at all in any way in terms of plugging it in to the existing blood vessels that's there in a non-gynecoid pelvis?
Right. Okay. Uterine transplant has been done,
but
not into trans women. But uterine transplant into
female to female
cis women has been done, and there have been live births from the donated uterus. It can be things like the mother gives her uterus to the daughter who lost hers in some disaster, some accident, some whatever.
Some tragedy, yeah.
It's not a very common thing. I mean, most women between the ages of 16 and 50, the vast majority of them hang on to their uteruses nowadays.
But the uterus is usually removed after birth of the baby?
They usually remove the uterus at the same time.
So they can then stop the immunosuppressive medication.
Yeah.
So in this surgeon who wants to pioneer this in a male anatomical pelvis.
Absolutely no reason why they shouldn't put a uterus into a man. Physically, technically, it's possible.
Really?
It can be done.
And there's no issue with
But the issues, I think the issues are largely ethical.
I mean, with regards to the sort of ethical conundrum of what we've just spoken about, in light of the Olympics next year in Paris and the increasing amount of transgender women competing in the female category in sports, I know the International Olympic Committee had certain designated criteria in terms of how much testosterone would be appropriate. So trans women in female categories, they would have to have at least a less than 10 nanomoles per liter of testosterone.
That's quite a lot,
That's
actually.
still quite a lot and above the female range of testosterone.
Exactly.
I mean, and the role of testosterone prenatally, so in the womb, and pre-pubertal testosterone and during puberty, that exposure to early life testosterone has lifelong positive benefits in terms of muscle mass, bone density.
Yeah, the trans women don't see them as positive benefits
Those are
necessarily.
positive benefits, but in terms of a physiological change, those are lifelong.
It's giving you a potential athletic advantage. Taller, bigger bones, bigger levers. It becomes difficult when you're talking the sort of mega bucks that top sportsmen can get, because then reasonably, if you're coming up against somebody who, for example, has been a triathlete as a man, who then transitions, is now a trans woman who is breaking world records.
Yeah.
In fact, I don't think any of them have. It means that competitive women's sport is difficult.
Yeah.
And I don't know. I don't know the answer. I mean, a few sports are gradually stumbling towards we'll have an open category.
I mean, because a lot of elite level female athletes have spoken out against trans women in the female categories,
and I think that's reasonable. I think I can understand completely why they would do so, because at their elite level, they're making their money out of competing at sport.
Now, some of the myths around feminizing surgery and just gender surgery in general that I've seen in the news outlets, and a lot of people online comment that a lot of it is psychological, which it's clearly not. But in terms of the psychology of wanting feminizing surgery and gender dysphoria in general, how much of a psychological component and is there?
Well, psychological suggests that it might respond to treatment, if you see what I mean. Which
exactly. Which is why. So people saying
this is the way your brain is built.
Yeah,
it's the same as people being left-handed.
Yeah,
and I've got a friend who's South African, and he can remember at school that the left-handed kids had their left hands tied behind their backs because they were not allowed to use their left hand to write.
Even more recently, as a junior surgical doctor years ago, when I started on orthopedics, I was banned from using my left hand. I had to only operate and stitch with my right hand, I was told.
Yeah. It's about as stupid as that. If you've got somebody who's left-handed, nowadays nobody would dream of saying you must write with your right hand. Put your left hand,
It's the way your brain is wired.
That's the way your brain is wired.
Yeah.
Interestingly, if you're looking at left hand, right hand, there's a higher proportion of left-handers who are trans than right-handers.
Really?
There are more right-handers who are trans, but the proportion of
Do you think in the UK specifically, we are ahead of the curve or behind the curve when it comes to progress in gender surgery compared to other countries?
We've got more mature gender services than in a lot of countries. Yeah. And interestingly, that's religious as well.
Yeah. Okay.
If you go across Europe and Asia, you can pretty much predict what sort of gender service you're going to have based on the religion.
Wow.
So the Protestant countries, Belgium, Northern Germany, Holland, us, you can predict we'll have established gender services going back to the 50s, 60s.
Wow.
The Catholic countries, typically it starts in around 80s, 90s, far less mature services. And Greek Orthodox, Russian Orthodox has only really just got going in the 20s, in the 2000s.
Wow. Well behind the curve.
A long way behind.
So James, before I let you leave, I know you're a busy man. You have a question for me. I don't know what it is, so shoot.
Right, okay. You're a general surgery, I think.
Yeah, general surgery.
You're going to come and join me? What about coming and doing gender surgery?
I would love to be involved and see you and assist you. I mean, I have not done urology for a number of years now.
You don't have to do urology.
You don't have to do urology?
As a general surgeon, you could do gender.
Really?
You could come and do vaginoplasties.
But I've never operated on that before. I've been doing bowel cancer operations, gallbladder operations.
Well, if you can do a laparoscopic anterior resection, you'd be very useful doing the peritoneal vaginas.
Interesting. Wow.
And we need people who are interested, enthusiastic, and capable. I suppose the capable is the most important bit, but yeah.
So what is the training pathway after someone finishes their surgical training in general surgery, as I will do in probably 18 months to 2 years?
At the moment, we've got some fellowships in gender surgery, and you'd come and go for one of those for about a year, and then you'd be trained to do gender surgery.
Wow, incredible. That is incredible. That is something to consider.
Yeah,
I think we'll have to have a chat off air.
And anybody else who's listening to the podcast who's a surgical trainee, who if you've got to be doing urology, plastics, general surgery, or gynecology to do genital surgery. But if you're doing any of those things and you fancy doing something really quite exciting and I wouldn't say niche, but really quite exciting and actually extremely worthwhile, come and see me.
Yeah, absolutely. Thank you. Thank you so much for taking time out to come and have a chat to me, James.
Yeah, pleasure.
Thanks to James Bellringer for that really enlightening conversation. And, you know, the vocabulary and our understanding of gender surgery is constantly evolving. So, you know, as someone who treats men, women, transgender patients as well, it's important to be up to date and up to scratch with not only terminology, but also advances in science, medicine, and surgery. Okay, it's now time for If It Ducks Like a Quack. And I've seen so much nonsense online, and I've recently been forwarded by dozens of you this specific video about someone talking about mouthwash and how mouthwash is incredibly dangerous for your oral health. Is that true? Is that a myth? Well, as always, it's not a black and white picture, and there is some nuance, and I want to give you the science. So as with most places in your body, your mouth, your oral cavity, is also home to various bugs and microbes. And it has its own little ecosystem inside your mouth, the oral microbiome. And just like the microbiome in your gut, in your skin, everywhere else, you need to take care of this, you know, delicate tropical rainforest of microbes inside there as well, which includes flossing, brushing your tongue, which a lot of people neglect, and obviously brushing your teeth a couple of times a day as well. And selective use of mouthwash can be suitable as well. And this is where the nuance is. Now, if you're constantly using mouthwash on a regular basis, what has alcoholic content in it, so the alcoholic mouthwash, that can actually be counterproductive towards your oral health and your oral microbiome, because the alcohol can wipe out some of the beneficial bacteria which actually produce nitric oxide. And nitric oxide contributes towards regulating your blood pressure. So you're not going to get high blood pressure by just using alcoholic mouthwash, but if you're already at risk of high blood pressure and you have a bad oral microbiome health, this can contribute to poor cardiovascular health as well. And it's often noted that people with poor dental health and poor oral health have an increased risk of heart issues as well. So it's, you know, important to keep that in good standing. You can use mouthwash, and mouthwash is not going to make your dragon breath disappear. It's just going to mask it. But you can do things instead of mouthwash by flossing and brushing your tongue. Now, a lot of the plaque that's produced and the biofilm that's produced by the bacteria end up on the surface of your tongue. And if you don't get rid of that, that can contribute to dysbiosis and bad oral hygiene. And a lot of people don't actually brush their tongue. So that is the number one thing that you are probably neglecting to do. But for the average person, regularly using alcoholic mouthwash is something that you should not be doing. So I posted a recent video on my Instagram account showing, or even commenting on, a person who has got ascites, which is a buildup of fluid inside the abdomen. And this person was having an ascitic drain, which is where the fluid inside the abdomen is drained off. Now, usually you can get a buildup of ascites, an excess buildup of ascites, if you have advanced cancers, if you have liver cirrhosis, liver failure, if you have really horrible infections in your abdomen. All of these things can produce a buildup of ascites, and it can cause, you know, infections, trouble with abdominal pain, trouble eating. So sometimes it's removed during a procedure called a paracentesis. Now, there is this myth that you only get ascites and you only get liver failure if you're an alcoholic. Now, liver disease does not just happen with alcohol abuse and excess alcohol. There is a wide range of causes of, various infections, cancers, autoimmune conditions, genetic conditions, which can cause liver failure, and they have nothing to do with alcohol. You have non-alcoholic steatohepatosis. It's called NASH. So that's non-alcoholic fatty liver disease. That can happen in people. You can get cancers of the liver. You can get parasitic infections of the liver. You can get metastasis, so cancers from another area which is then spread to the liver. So common thing I see and I deal with is a cancer that spread from the bowel to the liver, a colorectal liver metastasis. So there's a bunch of things which can cause liver damage and liver failure, which have nothing to do with alcohol. And this is often a problem that I see and I have heard firsthand from patients, is that they have some liver complications or some degree of liver cirrhosis and liver failure, and they feel that they're often judged based on the history that they just got liver problems, and people think and they associate bad liver equals this person's been drinking alcohol. It's not the case. Just before we go, we have crowd science. It's your turn to ask me a question. And this week we've got Emily from Birmingham who asked the question, I've been advised by a medical practitioner that the only way to truly be healthy is to base my diet on my blood type, my blood group. I'm a vegan for ethical reasons. What are your thoughts on this type of diet as an NHS doctor? Oh dear, here we go. Blood type diet. So I'm going to give you the long version and then the short version. So it all started in 1996 when a naturopath who is not a medical doctor called Peter D'Adamo thought that you can have a blood type diet. So according to your blood type, whether you're O, AB, A or B, you can have a diet that's specific to your blood type that will help you lose weight and process food more efficiently and generally be healthier. And for some unknown reason, this crazy blood type diet got millions and millions of people on this type of thing. And there was even recent BBC documentaries on the blood type diet and books on the blood type diet. There's probably people selling courses on the blood type diet and even selling supplements to do with that stuff as well. And certainly the blood is involved in your diet and the digestion of food. When you eat food, it obviously transits through the intestines. The nutrients from the food are then transported by the blood to various cells and organs in the body. That bit is legit, and that is just science. That is physiology, normal human physiology. But the individual blood type has no bearing on our health when it comes to our diet in any way. That is pure pseudoscience and not biology. And there is zero evidence in the literature, zero, zip, zilch, nada, that the different macronutrients, the glucose, the fatty acids, the amino acids react to your blood type in any discernible way. So this is an absolute myth, and anyone who prescribes you a blood type diet is either not a doctor, and if they are a doctor, they shouldn't be. Okay, I hope that answer helped Emily, and I'm going to tease you with another question, the answer to which I'll be releasing on Crowd Science Extra, another segment of the show dedicated just to answering your questions. And Leslie from Argyll and Bute in West Scotland has asked the question, hi, is a large stomach apron always due to being overweight? No matter how much exercise I do or dietary changes I make, I cannot seem to reduce it. I'll be going into detail on this question from Leslie and more questions in Crowd Science Extra. We'll still be answering questions in our regular show, but if you want more, you'll get more. The first 2 episodes of Crowd Science Extra are available right now. Just visit the referral show page on Apple Podcasts and hit try free at the top of the page to start your free trial today. You'll then unlock the extra episodes which sit right under this one on the feed. And that is a wrap for this week's episode. If you want more Science-gasm, make sure you hit the subscribe button for weekly episodes of The Referral with me, Dr. Karan. I'll catch you next time.